Hi, everybody. We'll be starting shortly. I see we have 10 people on. If you want to let us know where you are from in the chat box.
Welcome, Laura from Argentina. Thank you for joining us.
I see we have about 13 people here so far. And our presenter seems like she may be a little bit late. But we do have her presentation. Oh, we also have to see, is Taborski here? Where is he? I think he should be on the video. I see Rachel is here. Oh, Irene is there. Okay, Irene, I have to move you over. That is the problem. Okay, Irene, I see you're coming in. Your camera is shut off and you're on mute at this point. I can unmute you. There you are. I see you.
And oh, she's on mute again.
There she goes.
Okay.
Hello.
There we go. Hello, everybody. Hello.
Hi.
So where do we go from here?
Let's just wait a few more minutes. We have Taborski McClellan supposed to be here. He's going to give his patient perspective. I thought that he would be online tonight, but I don't see him here as yes.
Yeah.
So we'll just wait another few minutes and then we'll get started. So while we are waiting, if you'd like to just put in the chat where you're from, that would be great.
You want to hear from me?
Not yet.
Okay. You want the participants to say where they're from?
Yeah.
Yes.
So while we're waiting, let me just introduce myself. My name is Josephine Grima. I'm the Chief Science Officer for the Marfan Foundation. I also like to introduce you to my colleague, Dominga No, who is going to be helping me in the background.
Yes, hi everyone.
And let's get started. So, let me just make sure my video sound is on. Sure, computer sound. I know I didn't do that. Okay. We have 22 people on right now. Dominga, are you host? You may have to, I think you got in before me, so you may have to.
No, you're listed as host. So
yeah. Slide is not forwarding.
Would that be that might be a PowerPoint?
Sure.
PowerPoint glitch.
Let me see. There we go. Finally. Okay, sorry for the delay, everyone. So welcome to the third and final week of the International E3 Summit, Educating, Empowering, and Enriching Our Community. It's brought to you by the Marfan Foundation and its divisions, the Lois Dietz Foundation and the VEDS Movement, and also our partners in Europe at VASCERN. We really want to thank everybody for making the summit truly historic. It has been by far the Foundation's largest event, with nearly 2,800 registrants from more than 72 countries. We hope you've all had an experience, had an opportunity to connect with people from all over the world within the app, and maybe you can maintain these connections after the summit. As you surely know now, you're not alone in this journey. We really want to thank our presenting sponsors for helping to bring us this programming, and that is Brigham and Women's Hospital and the American Communications Construction Company. So before we start the presentation, I would just like to let you know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or VASCERN. If questions arise or clarifications are needed about different opinions between session speakers, please contact us at marfan.org/E3ask, and we'll be happy to clarify. We also like to make sure that everybody knows we want to get your feedback on this programming. So after this session, you can rate the session right on your app where the red arrow is pointing where it says rate. So before we start our presentation tonight, I'd like to introduce our speaker, Dr. Irene Maumenee. She has been on our PAB since I've been at the foundation, so you came before me.
I think on year 2 I joined.
And she is an expert in heritable genetic eye disorders. So if you want to just say hello to our membership participating tonight.
Hello, I'm presently working at Columbia University in New York. We are building our clinic for patients with inherited eye disease and connective tissue diseases above all, and try to make this a center of excellence. So I hope I see a lot of you coming to New York in the future.
Great, thanks. So our first presentation is going to be a patient perspective, and we'll start with that. So.
Hello, my name is Taborski, McClellan, and I was diagnosed with Marfan syndrome around the age of 12. My diagnosis was brought to me by an ophthalmologist. As a young kid, I had very poor vision, kept going back and forth to the eye doctor to try to figure out why my vision was so poor, and that's when they did a series of different tests and put some different thoughts together, and that's when I was diagnosed with Marfan syndrome, which initially saved my life, because without my eye issue, which was the dislocation of my lens, I would have never known that I had Marfan syndrome. So since that time period, again, around the age of 10 or 11, I had lens dislocation in both eyes. And as an adult, in 2015, I want to say, I had a retina detachment in both eyes at different time periods. One was like 2 years later. So again, my whole opening of Marfan syndrome was due to an eye issue, which initially, again, saved my life, because I have been through other things as collapsed lung, aortic dissection, which is the major deal for the most part when dealing with Marfan syndrome or living with Marfan syndrome. But again, because of my eyes, that was able to get me to the next level of education, awareness, actually a group or a team of health officials, because again of my eye situation. Again, my name is Taborski McClellan, and thank you.
Okay, I'm happy to comment on this, if that's what the schedule is. Is that what you want me to do?
Nope, not yet. No? You don't have to comment on this. I'll just play your presentation first, okay?
Yeah.
All right.
Hello, I'm Irene Maumenee. I'm professor of ophthalmology at Columbia University in New York. And probably and hopefully I have met many of you in the past. I'm going to talk about the ocular findings in the Marfan syndrome and allied disorders. But I will primarily talk about the Marfan syndrome because the eye findings we see in the Marfan syndrome are typical of all of these disorders. I have no financial interest to disclose. What I would like to suggest you do is actually open, a way where you see the anatomy of the eye so that you don't get lost in the details of this. I remember medical school and I thought the eye was the most complicated thing in the world. So just do it and it might make your life easier. I'm going to talk about the Marfan syndrome, as I said. Simple ectopia lentis a little bit, and ectopia lentis at pupillae, but I leave out all the syndromes that give you the lens findings, the ocular findings that I will mention now in the next 15 minutes. The hallmarks of the Marfan syndrome are cardiovascular and ocular manifestations. So ocular is right up there with cardiovascular. And why is that the case? An eye examination helps define the clinical diagnosis. It is once you see abnormalities, you know that you are in the right ballpark and working in the right direction. The diseases that we are talking about are progressive diseases. The natural history depends on the underlying diagnosis. It varies between patients and between family members and between eyes. So it is asymmetric. And what you see in one family member is not necessarily the same between all of them. And so between patients with the Marfan syndrome, it may vary significantly. And so you just have to have experience of what you see in these diseases and how you deal with it. In addition, the Marfan syndrome itself is a progressive disease, and so are many of the subtypes. And so patients ought to have an annual or even more frequent evaluation if there are complications. When we look at the eye, we see the various structures, the cornea in the front of the eye, the lens behind it, which can dislocate in the Marfan syndrome. We see the sclera, which is the white of the eye. The retina is in the back of the eye. Choroid is the vascular system below it. And then there are external muscles that move the eye. And you have the optic nerve, which takes the image from the retina to the brain. And we'll talk about these structures because they all contain fibrillin, fibrillin 1 more specifically, and therefore can have complications. The ocular manifestations of the Marfan syndrome are enophthalmos. So it's Greek for meaning deep set eyes. So the eyes are deep set, you see the bones of the forehead sticking out. And it's primarily lack of retrobulbar fat. The fat that's normally behind the eye is missing in the Marfan syndrome, like many of the patients are just skinny. The cornea may be large, so megalo-large for cornea, and we'll see a picture of that in a little while. This is enhanced by the finding of a myotic pupil. Myotic means you have a small pupillae opening, which makes it difficult to dilate the pupil, but this enhances the appearance of a large eye. The lenses may or may not be dislocated. You can see retinal detachments. Patients develop presenile cataracts, and basically the surgical complications can lead to significant ocular manifestations. And patients will develop glaucoma at an earlier age than the normal population. Here we see a child with a neonatal form of the Marfan syndrome, and you see how deep set her eyes are. It's just that the fat behind is missing, as we see the lack of subcutaneous fat over her body. The eyes are big for the face. And we see here a big appearance of the brown and the iris and basically the primary part of the eye when you look at people. And that again is enhanced by the small pupil. The diameter of the cornea may be 12, 12.5, 13, and 13.5 millimeters. And normal is sort of 11 to 11.5. But so there is a 10, 15, 20% enlargement of the corneal diameter. And so, you know, people may say what beautiful eyes the child has, but you don't want big eyes. That's not good in ophthalmology. The lenses may dislocate, and that again is a progressive problem. You typically don't see that at birth. So at birth, the lenses are in normal position, and here you see in a dilated pupil, you just see the iris here, in the dilated pupil, you see that the lens is dislocated upwards instead of being fully behind the pupillae opening. And you see the zonules here that shine up as these lines that connect normally the lens to the ciliary body, which is the structure behind the iris, right at the periphery of the iris. Here in another patient who is older, you see not just a dislocated lens. So you see the lens here, which is this brownish, greenish, bluish structure. And you see the reflex coming back from the retina, this dark appearance. And this is just a photographic effect, where there should be a red retina, but it's just made this way. And you see the iris, which is hypoplastic. And that again is typical for the Marfan syndrome. You don't have the same number of crypts and furrows that people have. This brownish appearance in the lens is actually a cataract. And a cataract in the Marfan syndrome may appear in patients in their 40s, 50s, whereas typical in the normal population, it's sort of in their 70s and 80s. And here we see a dislocated lens. Why do I know it's dislocated? It is all rounded off. And the lens is normally like a lentil. It is flat in the normal eye. And here the zonules don't have the normal strength, and the lens will round off, which is its physiologic behavior. If you take a lens out of the eye whole, it will round off, just like fully round like a pearl, like in this child. And behind the lens, you see this membrane, which goes to the back of the eye. It's V-shaped, and that's a retinal detachment. So this is an eye where you see tremendous problems. I know that this is a young child, and so if you have this situation, you have the hallmark of a severely involved eye in a patient with the Marfan syndrome. And here's such a child who has asymmetry of the two eyes. You can clearly see that this eye appears smaller than the left eye. The left eye is looking down, it is dislocated, it really protrudes from the socket, and the patient has congenital glaucoma as part of the Marfan syndrome, in addition to a retinal detachment. What are the less common manifestations? There's a posterior staphyloma. Staphyloma comes from grape. It looks like a grape in the back of the eye. There may be lens prolapse into the anterior chamber and lens dislocation into the vitreous cavity, and there may be strabismus. Strabismus is rare in the Marfan syndrome. I've operated on very few patients over decades of seeing patients with the Marfan syndrome. It's just rarely needed. It is probably the most common therapy and treatment that pediatric ophthalmologists do, but in the Marfan syndrome it's rare. But let's look at the posterior staphyloma. It is actually an outpouching in the back of the eye. Here should be the macular area, should be a very fine, well-defined reflex right in the center. Here are the blood vessels that go to the optic nerve. And so this is not here. And if we look at the eye here in a patient, you see again the back of the lens. This is an ultrasound. And you see a tremendous distance, let's say from the back of the lens to the retina, to the back of the eye. When you compare the two eyes, here's the right eye for this patient, and here's the left eye, which has normal length. So this is a markedly extended eye, probably twice the size in diameter between the two eyes. And that's a finding you see in the Marfan syndrome. You see this asymmetry, that one eye got just too big. Very rarely do you see a prolapse of the lens into the anterior chamber. This patient was sitting in my office before I appeared at work, was just a severely painful eye and pain during the night. She was sleeping on her belly, and the lens that was dislocated fell through the pupil and touched the cornea, led to this patch of swelling. This is not an artifact of poor photography, but there is an area of ground glass appearance to the cornea. And that is very painful, but it's seen only, very, very rarely. I bet I haven't seen that in as many as 1% of the patients. But decades ago, ophthalmologists would routinely dilate or constrict the pupil in patients with the Marfan syndrome to avoid this prolapse. But it just isn't a feature of this condition, or such a rare one, that it really isn't worth giving daily treatment for this. But then the lens can also fall into the back of the eye. And we see the lens here, nicely rounded off, transparent, lying on top of the retina in the back of the eye. That is seen, after decades of progressive lens dislocation. There may be a minimal trauma in addition, child rubbed the eye, or the adult, or something happened, an elbow in the eye, and the lens may totally dislocate and finish up in the vitreous cavity. There's nothing you need to do. Patients tolerate that well, so it's really not an issue. But it's typical of long-standing lens dislocation in the Marfan syndrome. I mentioned asymmetry. And again, here you see the lens and the edge of the lens, the lower aspect, and behind it you see the clear path through the vitreous towards the retina, and here just, through the lens, the pathway. And you can give glasses when you prescribe it, either through the lens or under the lens. Both pathways are possible. And this is the fellow eye of the same patient. And you see how much less lens dislocation there is. So in this eye, which is the left eye, you can barely see the lower edge of the lens. So asymmetry is a problem because it leads to differences in refraction, in power of vision. So the patient will prefer the better sighted eye and may develop amblyopia or lazy eye in an eye like the left as compared to the right of these two eyes that we just looked at. So we have here the Marfan syndrome, and then really there are subtypes depending on the age of onset. There's a neonatal form, and there you may see microspherophakia rounded off like a sphere, a lens that's like a sphere and that is small. And you rarely see glaucoma, infantile glaucoma in these patients, but it's there. And it's a severe complication, and you need to take care of it. And you can see a detachment in the neonatal period on the first 10 years of life. Whereas retinal detachment in the typical Marfan syndrome, we talk about the classical form, will occur in the 30s, 40s, 50s, 60s, and even later. In the classical form, there's progressive lens dislocation. There may be nothing seen at age 5 or 6 when the child will be nearsighted. The child may annoy the family because it will sit on top of the television and everybody else tells the child to sit back. Child can't see him, so moves forward. So the path goes from there to the pediatrician, and the pediatrician sends the patient to the ophthalmologist, and the ophthalmologist sees nearsightedness but does not see lens dislocation. That does not mean it's not going to come. So it's progressive. And so, sort of globally, 65% of patients with the Marfan syndrome will show lens dislocation as the years go by. There is a higher number as the patients get older. And lens dislocation with the lens rounding off will lead to refractive errors. It will lead to nearsightedness. And in addition, you see astigmatism in these eyes, and that can be corrected with glasses or with surgery. And these eyes, if, as time goes by, you see the retinal detachment, the eyes will get stretched, the retina tears, and you see a retinal detachment, which is difficult to fix in the Marfan syndrome. And patients may develop open-angle glaucoma in their 30s or 40s, again at a younger age than the typical onset of glaucoma, which is a problem in patients in their 60s, 70s, 80s. And then there are patients who have mutations in fibrillin 1, who have no obvious lens dislocation all their life. Globally, or totally taking all the patients together, only 65% of patients will develop lens dislocation. But these delayed onset patients may show presenile cataracts in their 40s, 50s, 60s, rarely rapid total lens dislocation within 2 months or so, and retinal judgments maybe before they have any other symptoms. So what are the complications of this? They're high refractive errors. You typically can correct them with glasses or often, or you may need to remove the lens in order to get to a more normal refractive status. But a lens dislocation will induce myopia or nearsightedness and astigmatism. And then because of the asymmetry, you may have unilateral amblyopia. So one eye that's lazy as compared to the fellow eye. Or you have bilateral amblyopia because patients never receive the appropriate glasses that will help them correct the vision in both eyes. And you see patients, certainly more in the past than now, who have never had decent glasses, and it may take them 6 months, a year, or longer to build up the vision once the optical aberration has been corrected. Again, asymmetry is a problem because of the preference of the stronger and the better eye, which leads to a lazy eye on the weaker eye. And again, this may lead to strabismus or turning out of an eye. But once you have corrected the asymmetry with glasses or contact lenses or surgery, the strabismus typically corrects itself. An easy way to diagnose the Marfan syndrome is on measurement of the curvature of the cornea. The cornea is flattened in the Marfan syndrome. It's a very steady characteristic of the Marfan syndrome. And you have an increased axial length. The eyes are big compared to the normal population. A normal adult eye is about 24, 25 millimeters. And in the Marfan syndrome, you see eyes 30 millimeters, 34, 35. And these are the eyes that are at high risk at the time of surgery and at a high risk of spontaneous retinal detachments. What's the prognosis? In the past, it was poor. We see here a patient in whom the pupil was actually attached here to the edge of the cornea, to the white of the eye, right at that side. And the patient had terrible glaucoma. So I was able to insert scissors right there and cut through this hammock that had been formed and cut an opening into the iris all the way down to here, which put the iris and an opening right into the center of the cornea, where the patient's cornea was clear in contrast to here where it was all hazy. So that gave the patient a good visual access. And I operated for the glaucoma and created a filtering blade. This is like a sponge. And the fluid could leak out of the eye. And the patient had a good 5, 10 years, I don't remember the exact time, of good central visual acuity with that eye. Then slowly the swelling and edema and this whiteness moved over the pupillary axis. And she then needed a cornea transplant. But she really preserved vision for a long, long time. And here we have another eye, which is a glass eye. So these were the situations we saw a lot of, and we just don't see it anymore. We don't see it anymore because people understand the disease better. There are better instruments are out there to do good surgical procedures. So the whole combination just has led to basically no people appearing with a dog or a seeing eye dog on with a cane. It just has become quite rare. So there are still patients around who are in this predicament. But today the life expectancy is 70 or 2 years and more. And basically most patients can expect a lifetime of adequate to excellent visual acuity. But often here the excellent is the enemy of the good, and sometimes the risk of doing a surgical procedure may be more risk and lead to complications as compared to just getting good enough vision. So wanting more may sometimes be a dangerous dangerous ambition and a dangerous goal, as well from the side of the patients as from the side of the physicians who want to give their patients the best vision and think, I can do it, I know I can do it, and well, and then you see trouble. So there is sort of a balance, and the eyes and the patients who have the worst eyes are the ones where you want to operate, and they are the ones where the surgery is the most difficult. Surgery may be easy and straightforward in patients who have minimal manifestations, but the very severe ones, the situation gets tricky. So as we said, the complications are lens dislocation, 65% of patients, flattened corneal curvature, an easy sign to make the diagnosis, cataracts, increased axial length, 10-20% longer than in the normal population, glaucoma and retinal detachments. And that's because fibrillin is basically in every part of the eye. So you see the complications throughout the eye, leading to a fragile conjunctiva, which doesn't really matter, a flat cornea, lens dislocations because of the zonules that break, and the lens capsule is leaky, and fluid may come out of the lens and leak into the eye and create inflammation. The iris is hypoplastic. Ciliary body is part of the glaucoma issue. Same with Schlemm's canal. Lamina cribrosa is fragile, and with pressure, the patients may develop glaucoma. Sclera may be thin and more prone to trauma. Choroid does pretty well. And Borch's membrane again is doing okay. So again, patients with the Marfan syndrome show significant flattening of the cornea and increased corneal diameters. These are features that help ophthalmologists to make the diagnosis. And that's basically what you see in the Marfan syndrome. And here we see a family where really they have lens dislocation. And this was a patient, you know, among the first 10 pedigrees of Dr. McCusick's patient file. And the only findings that suggested the Marfan syndrome was that she had scoliosis. She was absolutely normal. And basically in this family, the disease of dislocated lenses mapped to the fibrillin locus on chromosome 15. And so they have a mild mutation in fibrillin 1. And that mild mutation leads to just mild lens dislocation without the other complications. This patient has sort of what's called a flocculus, has little iris remnants, and the pupil is dislocated towards 6 o'clock, 7 o'clock, depending on the eye. And this is ectopia lentis at pupillae, and these patients have lens dislocation. They are the ones who are prone to develop a pupillae block. And here's the patient, patient's right eye pupillae block, and the lens will fill the pupillae cavity, and you have to relieve that, and there are ways of doing that. And basically a lens like that ought to come out with relative emergency. Ectopia lentis at pupillae is called by mutations in ADAMTSL4, and it's a well-known entity, and we don't know what happens to these people with regard to the cardiovascular system as they get older, but they get into trouble with their dislocated lenses in the first 10 years of life. And here's another patient with these small, with lots of these little flocculi. That means little clouds coming off the pupillae axis. And these are patients who are at risk of cardiovascular disease, of aortic dissections. Thus, the Marfan syndrome is characterized by a variable phenotype, asymmetry, and a progressive disease. And these are all features that ophthalmologists have to take into consideration. Patients ought to have evaluations annually, if not more often when they show complications, and thus they have a lifetime of diagnostic of complications of the Marfan syndrome, and they need to be anticipated and treated and taken care of. But in this day and age, patients with the Marfan syndrome should have and be hopeful for excellent visual acuity, or at least very good visual acuity for all of their life. I thank you for your attention. Hello.
Hello. So you can put your video back on.
I don't need it, but what I would like to say is that Mr. McClellan, when he explained his eye findings, it really falls sort of into the middle of the Marfan syndrome. Just has the typical features of lens dislocation, of first nearsightedness, and then lens dislocation that leads to the diagnosis, and then a retinal detachment. So he's just a typical patient.
Yes. All right, so we thank you very much for that presentation. We have a number of questions that came in, and if other people have further questions, please type your questions into the Q&A box. And maybe Dr. Maumenee, you can answer some of these for us.
Sure.
So they should be on the screen now. Can you see them?
I can certainly see them.
Okay.
And
So
happy to.
Let me ask you the first one by Monique. And she is asking, is laser eye surgery still considered unsafe for Marfan patients, even in someone without lens problems?
You know, I've seen patients who had laser surgery. That is, you reshape the cornea, and they did very well with this. I think if somebody has relatively mild Marfan syndrome, you might just as well go ahead and do this. But you have to also take into consideration that the disease is progressive. And if you get a good outcome now, that maybe in 5 years, it may not really do and help you the way it did when you first had the surgery. So I think this issue of progressive disease needs to be taken into consideration, and you need to weigh it. If you do well with a contact lens, you know, that's the ideal way for years to get good visual acuity.
Okay, thank you.
See, and the cornea is thinner, not much, just a little bit, but you know, you don't want the cornea to get too thin. If you cut off some tissue from the anterior surface, because then the tissue may prolapse and you get into more trouble. And that was, you know, at the basis of people saying don't do it. But I think for some people it's just fine.
Okay, all right. So the next question is it possible to put lenses in several years after a lensectomy? Does this depend on the type of procedure to remove the lenses?
Well, I think you can always do it. The issue is always the same. Where do you place the lens? If you put it in front of the iris, which is easy to do, you often finish up with a lens that isn't large enough for the eye, and it may just sort of move around and act like a windshield wiper and actually create more trouble than you possibly want to deal with. If it's just sort of difficult. If you put it into the pupillae axis, and there are lenses that are made to put right there, they are tough and hard to put in. And then you can put lenses behind the pupil and suture them in. And that was the method I liked. And if it's well done and you get along well with it, it's great. And it can last forever. And then people have come to actually threading loops that come off the lens through the sclera, through the white of the eye. I don't know what the long-term outcome of that is. It has been done now for the last 10 years, and I think the results should be coming in.
I'm afraid that the loops will erode through the white, through the sclera, through the white of the eye. That the sclera that is thinner than normal, more fragile, will just not tolerate the loops. So it's really a difficult issue because there is just no good spot where to put the lens. You don't have the normal way of attaching the lens as you would in an adult cataract.
I see.
Does this make sense?
Mm-hmm. Mm-hmm.
It's just sort of a difficult issue to where do you put the lens and
Right.
what type of lens do you use?
Mm-hmm. 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 Okay. This question is asked by Laura. So if a toddler 5 to 6 years old is having a lensectomy and there is a possibility to fit a IOL, would you recommend it?
You know, I didn't do it. I've seen lots of complications, but from just that procedure. But what usually happens, you know, young doctors are full of energy and want to get it right and want to do the best for the patients. And I just am not sure that's a good idea ever. But, you know, well, it just depends. It just depends. You know, in principle, you should get better vision. But then the eye grows and the lens implant isn't the right power. You cannot very well refit a new lens. So there are just issues with this. And I think you do better with a contact lens or glasses. And many children do very well with glasses. They just love them.
After you after you have the lensectomy.
Yeah. You know, you have to replace the power of the lens, which is about 20-25 diopters. So it really helps, let's say, to move an object from infinity down 2.5 centimeters. You know, you look at an object, light rays come off and they are parallel, and you have to focus them to the back of the eye. And the lens does that. Your own lens does a lot of that.
Okay. So this next question is asked by Miriam. Can astigmatism be treated with laser in Marfan syndrome?
I suppose, you know, you have to measure where the astigmatism comes from. It can be originating from the lens itself, and that you cannot treat with the laser. But if it comes from the cornea, you can treat that, yes, unless the cornea is very thin. But often it's combined between the two, so it's part cornea and part lens, and you don't really get rid of it, but you may make the situation better. So it has to be individually measured and reviewed whether there is any sense to doing it, but you can certainly try.
Okay, so that's important to know when you're going to your doctor, and they should be able to tell you that.
Yeah, whether it comes from the cornea or comes from the lens, or what is the component of each one of these two, you know, the cornea or the lens.
Okay. Okay. The next question is asked by Lynette. Is it common after a lensectomy many years later to have a lens implant and several and severe problems with dry eyes? Ideas for relieving the dry eyes.
Well, you know, it's just the eternal thing. You know, you would like the vision to be better. You would like the eye to be better. You would like the patient to see like everybody, and you put a lens implant in. And then they get into trouble. So it's a cornea that is having trouble. There's nothing you can do but actually use artificial tears. And you know, who knows what happens in the long run. And hopefully, you know, it goes very slowly, declines very slowly. But that's an unfortunate complication.
I see. Okay. The next question is asked by Laura. Are intraocular lens implantation techniques such as ARG walls, glued IOL technique, or Maumenee procedure suitable for Marfan patients? What are the outcomes, and is there enough information yet? So maybe you want to explain what those different types of procedures are?
Yeah, Dr. Agarwal is in India, and he came up with the idea of threading the loops through the white of the eye, and having, you know, if you look at an IOL is an intraocular lens. It has in its center the optic. That is the optical part, the lens part. And off there come like, you know, loops, like C-shaped loops that are made of polymer mesacrylate, sort of made out of a plastic. And the more flexible the plastic, the easier. You thread those loops through the white of the eye. And I just am afraid that in the long run they will not do well. There is a doctor at the University of Illinois who has adapted this. And I should write him an email and ask him how his patients are doing. I said, you know, I would be afraid that they would get into trouble 5 or 10 years later. So I'll send him a note and ask him how patients are doing now and see what's going on. And I don't know what the Yamane procedure is. Sounds like a Japanese ophthalmologist. I don't know him.
Okay.
I think we just don't, I didn't know, but I can ask, you know, how the patients at the University of Illinois are doing.
I see. Okay, yes. And how long has this Agawal's technique been around?
Maybe 10, 15 years by now.
Okay. Mm-hmm. All right. Thank you.
Yeah.
So the next question is asked by Laura. So if a toddler 5 to 6 years old gets an intraocular lens, and then when he grows, it is not the correct lens, would another surgery be needed?
Yeah, you know, you can just continue with glasses when they outgrow their own IOL, or you can make a stronger intraocular lens than they actually need, and you can anticipate what lens they might need in the future. So you can just, you know, go that way, sort of say, I split the lens power that I think a normal child would need when they are 20, and with what they need now, and put sort of a halfway in there, and then hope that in the long run, they may finish up with thinner glasses than they would if they had no intraocular lens. So you could do another surgery. You don't want to do this. Or what I used to prefer is actually wait until the growth of the eye has stopped. So when somebody is a teenager and do the surgery then, the eye stops growing usually by age 15, 16. And you get, let's say, 6 months, 6 months measurements apart, and measure how long the eye is. And if the eye hasn't changed, I think you can go ahead and do the surgery then, and then get a better, you know, optical outcome that will hopefully be good enough for the rest of their life.
Right, right. Okay. So the next question is asked by Dennis. Is lens replacement surgery an option for a Marfan patient with silicone and nylon contact allergies? Concerns and what may be the alternatives to that?
Yeah, I think it doesn't. You use basically the intraocular lenses are made of polymer mesacrylate, which is a plastic. It's basically a clear, like a windshield, like a window plastic. Or in airplanes, it's used for the pilot's windows. So polymer mesacrylate, and then there's proline. The loops are made out of proline, and so it's neither silicone nor nylon. And patients tolerate it well, so it's really inert and quite well tolerated. So I have no real problem with the lenses that are being used.
Okay, great. So this is asked by Yvonne. If a Marfan patient has a lens detachment or a retinal detachment, how long do they have to seek medical treatment to try to correct the detachment before it's too late? So those are two different situations, and I think the amount of time that you have to correct it is two different things. So maybe you just want to re-explain that.
Yeah, so if the lens gets dislocated, you can correct it at any time. even if it has fallen into the vitreous, or you can leave it there. So you don't really have to take it out unless you're convinced that the patient is handicapped by the lens detachment. If it's mild, it really doesn't matter that much. So it's a question of asymmetry and timing of the surgery and make the patient the most comfortable. It's really refractive surgery. You try to give the patient the best visual acuity without glasses, the least thickness to the glasses, the least complicated glasses or contact lenses to make them see well. And so you can do that, and you can time that. If a patient sees 20/20 in each eye with dislocated lenses, you might just as well leave well enough alone.
Mm-hmm.
And many patients do. But a retinal detachment is that retina that's in the back of the eye. That's a film, and you have the photoreceptors, the actual neural elements in nerve cells that detect the visual stimulus and lead it to the brain. So if the retina is detached, that's when these nerve cells die. The nerve cells depend on the underlying choroid and retinal pigment epithelium. If they are not in contact, so that's the vascular supply and the actual biochemical center of each photoreceptor, the pigment epithelium, if they're not in the normal position, and the attachment between these elements isn't there, that's when the retina dies, and the retina has only so much recovery. It is a very sensitive tissue. So basically, you want to detect a retinal attachment as soon as possible and repair it as soon as possible. Mm-hmm. What is too late? Too late is when it's all scarred down. You can't really dissect it out into parts that can still see. If you have lost our vision in an eye because the retina has been detached for 3 months, 6 months, a year, you're not going to get anything back. Or the eye has started to shrink, then you just make the situation worse. So ideally, you fix a retinal detachment as soon as there are symptoms. As soon as the patient is aware of it, that there is something wrong, you should go in and have the doctor look at you, and you ought to have an eye doctor who's familiar with you, where you go routinely, who takes care of you, and who understands your situation at any given time.
Yeah, can you just go over what the symptoms of a retinal detachment are for those that don't know, so they would know when it is to go to an emergency room?
Yeah, a retinal detachment is actually like a curtain coming over your vision. You have like a shadow come over your vision that wasn't there before.
Mm-hmm.
You can't see in a certain area, and it will be in one eye, not in both. So it will be new, or that's actually not really a right explanation. Children may not complain when they get the retinal attachment in the first eye, but they complain when the second eye gets detached.
Mm-hmm.
And then the vision in the first eye is already bad, and maybe it's impossible to retrieve it.
Mm-hmm. Mm-hmm.
So that's why people need to go at least once a year. Children, often it's best they come twice a year. But if everything seems stable and the refraction isn't bad, they can be seen once a year. So it just depends, and it needs to be individualized. And I think you have an ophthalmologist who has experience with that. He say, "Oh, I think you're going to be all right." Mm-hmm. But if a kid has been in an accident or has been in a fight with a brother or friend and been hit in the eye, an eye should be looked at.
Okay.
So it's really getting a curtain that comes over the vision. Children won't complain. Adults will notice it and say something is wrong.
Mm-hmm. Okay, thank you.
Okay.
It's almost 8:30. Would you mind staying on a few more minutes just to finish a few more questions?
Sure, fine with me.
Okay. So this question is asked by Miriam. Is it okay to remove lenses without implantation? And I think you've answered that before, but you can briefly
I think
answer
it's
it again.
just fine.
Mhm.
So if you take the lens out, see the lens sits there, it's rounded off, it's tilted, and it may actually move around, and that gives instability in vision. So patients can be bothered by their dislocated lens. So you can take it out and not put a lens implant in, and just actually give the patient glasses or contacts, and they may be fine. And they may be seeing 20/20 forever, and it's not a big deal. It's really difficult to put an implant in because the optics are really, we have no good way. The optics are okay to figure out and to calculate, but you have no good spot where to fixate the lens implant. And many places where you put it, it will create more trouble than it does good. So it's not an easy decision to make, whether to put an implant in or not. But obviously, if you have an implant and you're closer to your peers and it looks more normal, and so patients love it. They're not that handicapped. They don't have the thick glasses. They don't have the details to bother with. So I can see why people want an implant. They want to be normal.
Okay. So this one is, quite specific question to this personal situation. But she said that she had natural subluxed lenses removed in 2012, 2013. The lenses had developed cataracts and burst, causing extreme pain and glaucoma. So each was removed in emergency surgery without the opportunity to arrange for a corrective lens implant. Is having a corrective lens implant an option for her? She's 46 years old and she's worn glasses or contacts since the age of 2.
It certainly can be done. It just depends what the status of the eye is. If there is long-term problem after having had, the cataracts with the lens capsule breaking and glaucoma attack, then I think you may be hesitant to go back in. You don't have a zipper in the eye. You just need to treat the eye gently. And too much surgery may just not work out. But it may also say, the physician may say, your eye looks really good and healthy. Why don't we go ahead? And so it's individual and can certainly be handled. If you have worn contacts since age 2 or glasses, you may just be tired of them. But also remember that even after you had the surgery, you will still need glasses or contacts, but they will be a lot thinner than what you have had all your life.
Okay.
Okay.
So this one is asked by Yvonne, and I don't know if I know how to say this word. Is ptosis of the eyelids?
Just silent P. Drop it.
Silent P. Ptosis of the eyelids, a known sign or symptom in Marfan patients, and can ptosis of the eyelids impact vision?
Ptosis is not a problem in the Marfan syndrome. It's not a primary problem. But obviously anybody can have ptosis. It's not rare, especially as you get older. But if it impacts vision, you can lift the lids, you can do surgery. So there are ways of dealing with it. But typically Marfan patients do not have ptosis unless their eyes are irritated, and then patients have a protective ptosis. So they keep their lids half closed because the eyes are painful to light, and you have dry eyes. All of that may help, but it's not a typical feature.
Okay, all right. This question is asked by Michelle. So she's saying her right intraocular lens dislocated on July 13th, and it floats from the back of the vitreous cavity to the front of her eye constantly. What are the risks to her vision the longer the surgery is delayed due to COVID?
It typically doesn't matter. People can tolerate a lens in the vitreous cavity for about 20 years. That's the number I use. And some it's 30 and some it's 15, but you know, 20 is a pretty good number. So you can live with it for a long time. Well, it bothers people, you know, when they look down and put their head down. It bothers them when they play golf. It bothers them when they swim. It bothers them when they lie on their belly.
Mm-hmm.
But, you know, basically, if you learn to keep your head up, it will fall into the bottom of your eye, into the cavity,
Mm-hmm.
and it will lie there and you'll be all right.
Okay.
So as long as there is no inflammation in the eye, you're fine.
Okay. All right.
No worry.
So this one is asked by Laura. Could a dislocation downwards of the lens be indicative of something?
Well, not really. More patients start out with lenses that are dislocated upwards. And then with time, they come downwards and finally they go into the vitreous. So, you know, like in that cavity and lie there. It's not really, it may be a progression for a given patient, but some patients have downward dislocation at a young age.
Mm-hmm. Mm-hmm. Okay. So this is asked by Laura. Are blue sclera seen in Marfan syndrome?
You know, yes, but it's just, what does it indicate? A blue sclera is sort of a sign that the white of the eye is too thin. You actually see the blood vessels that are under the sclera, so-called choroid, shine through. And sclera may appear bluish.
Okay.
It doesn't really matter. It's sort of a feature, and you see it and you recognize it.
Mm-hmm. Is it more common in other connective tissue disorders?
It's very common in osteogenesis imperfecta.
Okay. Mm-hmm.
There, the sclera is even thinner, and you always see it. You see the blue sclera. They have just bluish eyes, but you see it in patients, and you just don't even note it. It's kind of okay.
Okay. This is asked by Sheila. What is a safe pressure for glaucoma patient with Marfan's?
Well, below 20.
Mm-hmm.
It's basically the same as for anybody.
For anybody else, yeah.
Yeah, for anybody else. So the glaucoma, you measure the pressures in the front of the eye. The damage occurs in the back of the eye. So there is damage on the ganglion cells, on the optic nerve, on the photoreceptors. So the damage is not in the front of the eye, but you don't tolerate glaucoma, you know, for decades. Depends eye, the pressure is a pressure of 30. And with if there's visual field loss, you just need to do something.
Mm-hmm. Mm-hmm. Okay. So this is also asked by Mary. Can you comment on the use of SLT for glaucoma?
I don't even remember what SLT is. Scanning laser, I don't know.
Not sure what
laser, it's laser something treatment. SLT, I don't know where exactly they want to put it. So basically that's probably a glaucoma treatment. And it, you know, I see no problem why you wouldn't use it. So you do it to the angle. There is a treatment where you actually use laser beams and cut out the area where the eye creates a fluid. You reduce it so that there is less glaucoma, and I see no reason why it wouldn't be used.
Right. Okay, so this one is asking about that they read that sutured intraocular lenses, for sutured intraocular lenses, some doctors have doubts regarding the durability of the suture threads. What is your experience?
There's no question the sutures break.
Yeah.
We used to use 10-0 nylon sutures, 10-0 Prolene, and after 10, 15, 20 years, they would break. And so it just was a problem. And then we used to go to next size up to 9-0 Prolene, and they lasted longer. But, you know, if you have surgery when you're 6 or when you're a teenager and you have a life expectancy in your 70s, it's just not going to be good enough. So there is a problem. And so whichever way you turn, there's a problem with the intraocular lenses. But you may also say, you know, you just resuture it and try to get away with it. But there are just problems whichever way you go. It's just that the normal ligaments, the normal suspension of the intraocular lens, of your own lens, is just not there. You just don't have the zonules. So you just have to create some system where you suspend that lens. And people come up with new ideas all the time, but it's just difficult. It's a difficult issue. But I know one thing, I wouldn't want an intraocular lens in the front of the eye.
Okay.
So in front of the iris, because that's where I've seen a lot of damage and where I've taken the lenses out.
Okay. All right, so on to the next question, asked by Tina. Can you explain spontaneous sclera tearing in Marfan's? She was operated in '97 and don't know if more tears may come with age or vision consequences from that issue that she had.
Yeah. You know, it's a white of the eye. You know, the white of the eye is just fragile in the Marfan syndrome. It's thinner than normal. And the eyes are big, so it's stretched and it may just tear. And you can sometimes see the blood vessels sort of come forward and shine through. And that gets into the thing of seeing the eye is bluish. The white of the eye is bluish. That's all the same issue. And you get the thinning of the sclera. It shouldn't make much, it's by itself a lot of trouble. But that also means that the retina inside the eye is stretched and you're maybe at an increased risk of a retinal detachment or a retinal tear, and you may need to fix that.
Okay.
And be careful and think about it.
Okay. All right. Well, I think that's all the questions. I want to thank you so much for all your thoughts and comprehensive answers there. So just some final thoughts. If you have other questions or you need more answers to them, you can submit those questions to marfan.org/E3ask. Please be patient because we have a lot of questions coming in and it will take some time for us to get back to everyone. We would also like you to complete the session survey as we showed you earlier. In addition to this session's feedback, we encourage all the E3 participants to complete the E3 Summit survey. Whether you attended one session or all 70, your input is invaluable to helping us build future programs and services that meet your needs. To show our appreciation for your responses, 3 E3 Summit survey submissions will be selected from random to win a $50 prepaid international debit card. So don't wait to submit your survey. Only surveys submitted by 11 p.m. Eastern on Wednesday, September 16th will be eligible for the drawing. So you can see this survey at marfan.org/E3 survey or by clicking the link on the E3 Summit homepage, which is marfan.org/summit. And finally, you know, we hope that you would take advantage of visiting the exhibitors in our virtual exhibit hall, connecting with others in the community for getting to know them and continuing those collaborations after the summit. If you are active on social media, you can use the hashtag E3Summit20 to tag us. And if you want to help us make more programming possible, you can donate at marfan.org/donate. And just on a final note, coming up after the summit is Aortic Disease Awareness Week. It's September 19th to the 26th. Again, this is another worldwide event, and it's powered by the Marfan Foundation. And we hope that you will all participate in our awareness project, which is raising your hands to raise awareness to the risk factors for aortic disease. Information is available on the Summit app and on our website and social media. And Irene, do you want to make any final comments before we end?
Sure, it's my pleasure. It was my pleasure to talk to you. Just stay in contact, take care of your eyes. And I think there are a lot of good ophthalmologists in this world, and there are a lot of good instruments today to help everybody to maintain vision for the rest of their lives. So good luck to everybody.
All right. Thank you very much. So long, everybody. Have a good night.
Good night. Thank you.